We are thrilled to be presenting today's timely webinar entitled The Challenges in Providing COVID-19 Testing and Vaccine Distribution for African American Communities. Our program today is sponsored by the ABA section of Civil Rights and Social Justice, and today's presentation is one of many in a series commemorating Black History Month. We are actively planning additional program on a variety of issues, so please visit americanbar.org/CRSJ for updates on these informative programs. We'd like to thank our outstanding co-sponsors, the law firms of Sanchez, Maurer, and Desiderio, along with Friedman, Boyd, Hollander, Goldberg, Urias, and Ward, for their generous support of this event. During today's program, we encourage you to ask questions of our presenter, but do it through the Q&A function, not the chat function. If you do not see the controls at the bottom of your screen, just make sure that your screen is not idle. We will address your questions at the end of the presentation. We will be sharing a recording of this program to everyone who has registered so that you can share it widely with your networks. And with that, we are thrilled to bring you today's program, The Challenges in Providing COVID-19 Testing and Vaccine Distribution for African American communities. Our presenter this afternoon is a woman who has been a leading voice in discussions regarding the COVID-19 pandemic, with appearances on CNN, The Today Show, Roland Martin Unfiltered, in the New York Times, and many, many more. She is the medical director and chief of the Infectious Diseases Division at TriCore Laboratories in Albuquerque, New Mexico, as well as an associate professor in the University of New Mexico School of Medicine, Department of Pathology. In 2016, she was nominated, are you ready for this? An NAACP Image Award for the children's book that she authored. If that isn't enough, our presenter today was chosen to fill a vacancy on the city council in her hometown of Rio Rancho, New Mexico. So let's give a warm, rousing welcome for our presenter today, Dr. Karissa Culbreath, and I'm handing the platform over to you.
Thank you so much, Pamela, for the wonderful and very kind introduction. And certainly thank you to the organizers for allowing me to share with you all today. I was thinking maybe people would be a little bit tired of hearing about COVID now that we are nearly and just now a year into it. But what we see is that there continue to be challenges as we come through each layer and each phase of the pandemic. And so it gives us an opportunity to see the challenges that we have faced in so many other areas. And I think now is a pivotal moment for us to really begin to see how we can take action, how we can move forward, and hopefully how we can make some larger, more substantive changes across the entire spectrum of diseases that we face in this country. So thank you again, Pamela. Thank you to the organizers, to the committee organizers and the committee at large. I appreciate the opportunity to be able to share, to educate, and also to just communicate opportunities for interdisciplinary interaction. So many of the challenges that we face and we've seen with COVID-19 have demonstrated that this isn't just a healthcare issue, that this is really a social justice issue that we are seeing. This is a health justice issue. And so to be able to have these type of interdisciplinary conversations where me as a scientist and clinician get to have the opportunity for conversations with those of you who are actively fighting in social justice religious realms and in the legal field, it really gives, I think, the space for us to move the needle much better than we could if we were, and as we have been operating in many cases separately, by us coming together and galvanizing around the issues that we have been presented with COVID-19. It will then set the stage for attacking all of the other issues that we have seen and all of the other pandemics that have plagued our communities. We have demonstrated that we have not yet figured out how to address pandemics through a lens of social justice and through a lens of identifying and responding to marginalized communities. We've proven that we've not done a great job of that. Hopefully this pandemic was large enough and global enough and indiscriminate enough that it impacted so many communities that as a society, as a nation, as a world, we can now come together and figure out how we can make these larger changes that are indeed necessary. So with that, I'm going to share my screen. And please, I certainly look forward to seeing questions and comments in the Q&A section. And I look forward to presenting to you today. So I'm just going to share my screen here and we will begin, I believe. All right, so I hope everyone can see the screen. So, just to give a little bit of retrospective to kind of place us into context for where we are now and how we got here. So back in December of 2019, a new virus called SARS coronavirus 2 was first identified in Wuhan, China, in December of 2019. And so there's still active and actually very active and ongoing conversations with how the virus emerged and how the initial response was identified. But the emergence, as we're aware, is due at least in part to some exposure, potentially in some seafood markets or other associations with some secondary hosts, as we define them. So other secondary animal hosts in society. And so then in December of the end of December of 2019, the Wuhan Municipal Health Commission reported this cluster of pneumonia cases. In a very short time, January 21st, 2020, the CDC confirmed the first case in the United States. By January 31st, the WHO issued a global health emergency, and on March 13, the COVID-19 was declared a national emergency. California became the first state to issue a statewide stay-at-home order, which we know was then identified as kind of a state's choice to define how each state would respond individually to the response to the pandemic. And that happened on March 19th. And we've seen waxing and waning in individual state decisions around control and restrictions related to the pandemic. By May of 2020, the US deaths passed the 100,000 mark. So I think this is amazing for us to think about that in January of 2020, there was the first case of COVID-19. And then by the end of May of that same year, just 5 months later, the US deaths related to COVID-19 passed the 100,000 mark. And then in June, the number of cases in the US reached 2 million. And then we see this very exponential spread. So we go from 2 million cases from January to June, but then from June to July, we now add 1 million additional cases. And so we see how the virus spreads really exponentially. And we've seen all of this play out in our own personal lives, right? So by August, COVID-19 was the third leading cause of death in the United States. So that's August of 2020 was the third leading cause of death in the US. By September 28th, the global number of COVID-19 deaths surpassed 1 million. So it took less than a year for this virus to spread across the globe, which really gives us an eye to the global economy and the global impact that we now have and how viruses change. And our response to viruses, really, it has to be a very global response for how we look at this and how we frame what the next pandemic response would be. So in less than a year and just over 9 months, we go from cases first being identified in December to 1 million deaths in the globe. And then, hope on the horizon. So in December of 2020, the FDA grants emergency use authorization to Pfizer, BioNTech, and to the Moderna vaccine. And as we know that there's other vaccines that are coming on the horizon, and I'll be sharing a little bit more about that as we go forward. And so really just taking a pause to consider the whirlwind that we've all experienced. It's been a global whirlwind that we've all experienced, and certainly a pause to think about and to commemorate those who have lost their lives to this pandemic, and those who continue to suffer long-term effects of the infection, and recognizing that we are still actively seeing new cases. And so this response and the needs for COVID response for both testing as well as vaccination, they are not finished. This is not something that is done once the vaccine became approved in December. Now is still the need for response through both testing as well as vaccine distribution. And so just to put some things in context, I promise, even though I am a scientist, I do know my audience. So I don't think that you all came today to hear a lot about RNA viruses and the various mechanisms of action of the RNA viruses. So I will spare you that, no worries. But I do want you to just kind of have in context that SARS coronavirus 2 or COVID-19 is part of a family of larger coronaviruses, which coronavirus as a family generally cause just the common cold, and we test for that, for the common cold that coronaviruses cause. But there are some severe coronaviruses, SARS-CoV-1 or SARS-CoV, so that would be the original SARS, the severe acute respiratory syndrome. MERS coronavirus is the Middle Eastern respiratory syndrome. And then now we have COVID-19 or SARS-CoV-2 that emerged. And what we know is that while this is certainly older data and older figure, but I think it kind of put things into an important context when we look at COVID-19 in the context of some of the other severe coronaviruses. And we see that COVID-19 has a lower case fatality rate than certainly some of the other coronaviruses that have emerged. But putting that lower case fatality rate into context of what we've just experienced and what we continue to experience demonstrates that it doesn't take a high case fatality rate to have a huge impact on the global population as well as local communities, especially when we start to lay into context the impact of social determinants of health and disparities when reaching the most affected communities. So just a little bit of timeline. This is a graphic that anybody can go and access, and I have the link there on the bottom. I think it provides just an interesting view of the pandemic. So this is March 12th, 2020. And so this is an important day, for my laboratory in particular. It's the day that we began to do our very first test for COVID-19 for SARS-CoV-2. So this is the day that I kind of have memorialized in my mind of the day that we began testing. And so we can see what the global impact of testing and what we see there. So at that time, there were just over 100,000 confirmed cases, 4,700 deaths globally. If we shoot forward several months and we see, there at the end of August, now the global cases upwards of 24 million cases, and over 5 million, almost 6 million cases in the US. And we start to see the distribution of cases globally shifting throughout the population. And then I just pulled this up just a couple of days ago. So now over 100 million cases globally. global deaths over 2 million. And of course, we know the very, very sad tale that here in the US, there's over 460,000 deaths just here in the United States. And so this impact of this pandemic has certainly been felt worldwide. But again, specifically, we've got to think about that this isn't just a global problem and is a problem that is literally touching every continent, but there are certain communities that are being impacted differently. And so we've got to look then at how those changes are driving this pandemic, and that if we can address not just the global view, but the local impacts of how marginalized communities are specifically impacted by this pandemic, then I believe we can start to make some headway as we continue our fight against the virus. When we look at in the US, this is data from the CDC of COVID-19 hospitalization and death by race and ethnicity. In cases where race and ethnicity were provided, we're going to look at these numbers are all compared to white non-Hispanic persons. So we see for cases in almost every category, there is certainly a disparity, right? But it's not just at the level of cases. The disparity isn't that big when it comes to the number of cases, when it comes to comparing to the white non-Hispanic person. So we see with cases, the change or the increase in the disparity, it ranges from just underneath 1 or just over 0.5, so at 0.6 for Asian non-Hispanic persons, up to 1.8 times the number of cases in American Indian and Alaskan Native persons. But we see this large jump then when it goes from cases to hospitalizations as well as death. So what we see is that while the largest disparity isn't just at the level of cases, we start to see that when we start to look at of the cases, the persons who are hospitalized, that disparity really jumps with 4 times the number of individuals, American Indian and Alaskan Native individuals who are hospitalized, 3.7 times the number of African Americans who are hospitalized. And then with deaths, compared to white non-Hispanic persons, we see 2.6 times the number of Native American and American Indian deaths, 2.8 times the number of African American and Hispanic or Latino persons. So we see here, just right here, it lets us know what we all have either seen on the news or experienced in our own personal lives, that there is certainly a disparity, and it just does not only the number of cases, but there is something within the system where we see that those individuals who go from being defined as a case to somebody who is then hospitalized, and then ultimately and unfortunately those who die, there is a disparity when it comes to the access and experiences that individuals have with healthcare systems that lead to hospitalizations, and then that the time that people spend within these healthcare systems, unfortunately, leads to increased disparities in the individuals who die of the disease. And so what we want to do here is not just look at, again, the virus and the RNA and the DNA, because there's really nothing inherently different about the way SARS-CoV-2 infects or causes a disease in white non-Hispanic persons compared to Native American, Black, or Latino individuals. Now what we're seeing is the impact of social determinants of health on our communities. Again, none of this is new information. There is an abundance of literature, and I'm sure many of you work even now in health justice and dealing with social determinants of health. My hope is that because of the impact of this pandemic, how it was felt worldwide and across the board, that we can now galvanize our energies towards truly beginning to address the systems and structures that impact our health. And so we have this question, what determines health? And many people, if you just ask them off top, people who are not versed in social determinants of health, they may say it's something about your genetics, something about your DNA. You're just born this way. You're born with a specific predisposition to a certain disease, or maybe there's just certain catastrophes, right? Certain natural disasters or a car accident or something like that, or maybe you're exposed to a different type of disease agent. Or, people go ahead and go into the space of, well, maybe it's just your fault. It's your personal habits. It's just the way you eat. It's just the way that you choose to live your life. Or maybe it's your moral responsibility that's part of and really defines an individual's health and leads somebody to go and see a doctor. But what we know to be true is that greater than any of those other factors, the reality is that the social determinants of health, the places where we play, where we work, where we learn, and where we live, are a higher predictor of our health and our ability to achieve even better health. And these factors are overlaid by these larger structures of population, place, and power. And so when we combine all of these things together, these social determinants of health really have a stronger impact on who we are and how healthy we are than any of these other factors. And so and one of those biggest pieces that I want to point out here is the impact of implicit bias in medicine. Because as we've seen through the COVID-19 pandemic, and I'm going to share certainly one example a little bit more in detail, is that the implicit bias that we know that marginalized communities experience, and we know that specifically Black communities experience, has an impact on our overall health and well-being. What we've seen in data is that physicians are more likely to underestimate the pain of Black patients compared to non-Black patients, and thus end up giving them less pain medicine if they give them any pain medicine at all. Additionally, there's unfortunately still an incorrect belief in these fundamental biological differences between Black and white patients. There was a study of medical students, and somewhere around 20 to 25% of medical students thought that Black patients' skin was thicker and thus perceived pain less than a white patient. There was an amazing perspective in the New England Journal of Medicine entitled "One of Us" that shared these three stories that we all, many of us have likely heard about. In some cases, Dr. Susan Moore, who I'll just share a little bit about more in a second. She's a family physician who died of COVID-19. Dr. Shanice Wallace, here in 2020, she was a pediatric physician who died of preeclampsia. Breonna Taylor, right? She was indeed one of us in the medical field because she was an emergency department technician. She was an aspiring nurse, and she died of a botched no-knock warrant. And so this implicit bias in medicine, it does not even exclude those who practice in the medical field. Those who practice and experience care in the medical field, who are themselves part of the medical community, are not even immune themselves of experiencing the implicit bias in medicine. So I want to share a little bit more about Dr. Susan Moore, to think through this around the eye of COVID. So there was some social media interaction about this. She posted a video on one of the social media platforms. Dr. Susan Moore, she was a family physician. She was treated for COVID-19 at Indiana University Hospital North. She tested positive on November 29th. She had symptoms of severe coronavirus, high respiratory rate, high heart rate, high fever. She was coughing up blood. She had to advocate for herself, and unfortunately, her self-advocacy was considered a threat. It was considered too aggressive. And so she had to advocate for herself to receive pain medicine for the tightness in her chest. She had to advocate for herself to receive the CT scan to reveal that she had pneumonia. She had to advocate even for her own appropriate therapy of receiving antiviral drugs. Ultimately, she was discharged, but likely discharged. Perhaps she was discharged too soon, because 12 hours later, she returned to a different hospital where there she spiked a fever. She was still now had this decreased blood pressure, another sign of severe coronavirus. She returned to this hospital. She was treated for both COVID-19 and bacterial pneumonia, and she died 1 week later. So in the words of Dr. Susan Moore, this is what she said and the things that she said in her own Facebook or social media video that she put on. She said, although that I am in intense pain, the doctor made me feel like I was a drug addict, and he knew I was a physician. Back to that misperception of pain and how we perceive African Americans, how African Americans are perceived when they request pain medicine. Dr. Moore further said in the video, I put forward and maintained if I was white, I would not have had to go through that. And the doctor never came back and apologized. And she says, those people were trying to kill me. Clearly, everyone has to agree that they discharged me way too soon. The reality is that even with Dr. Moore knowing everything that she knew, she still had to advocate for herself and for her own health. Ultimately, she still was not able to get the care that she felt like could have potentially saved her. And so then what was the response by the chief medical officer of the facility where many of these issues happened? You can see it for yourself and make your own judgments on the response. Some may say that it's just, the common response of brushing things over and trying to smooth things over of we take the accusations very seriously and we investigate. But at some point, we certainly must agree that there has to be a call to action, because Dr. Susan Moore's story is certainly one story that gathered many headlines, but I do believe that many people across the country would have a similar story, and maybe there's been individuals who have not been able to have the education and the background that Dr. Moore had to be able to advocate for themselves and yet still experienced a similar outcome. And so what's the need here is that we need to really look at and we need to focus on health justice. And this am I back?
Yes, you are back.
Okay. All right, let me share my screen again. I apologize. I think we've all been through this in virtual land. All right. Again, my apologies. All right, so when we look at, I'm not sure where I left off, but I'm going to keep going from here, this health impact pyramid. This looks at what are the factors that actually impact health that will have the largest impacts. And so we can talk about individual effort, and those were those early things about, doing better, living better, making better individual choices. But really, when we want to have a larger health impact, then we have to look at other factors, looking at the context where individuals have to make this, health decisions and the social economic factors that people face. And so when we frame the health disparity around COVID-19, I think this is all information that is well known, that we have many adults, 44 million adults who are underinsured. There are 2 million Americans still today who lack running water in their homes. And when we talk about washing our hands and we talk about doing the things that we need to do to be able to protect ourselves, there are 2 million Americans who cannot regularly wash their hands in their homes. We know that there's issues around the availability of paid sick leave among low-wage workers. There's the fear of deportation for undocumented migrants if they try to go and get testing or access vaccinations. And of course, I've described the implicit bias that's experienced in medicine. And so when we look at this specifically for COVID-19 and these regional risks, what we see in the red, and you don't have to look at this in detail, but what I want you to see is that red is an increased relationship between COVID-19 and a social risk, and blue is less of a risk. So red shows that there's this highlighted risk where in one frame is looking at household composition and disability, so the number of people that are in a household and household density. Another one that looks at minority status and language. And then another slide, this one over here, this frame, looking at housing and transportation. And so what we see is that the risk is not universal across the US, but there are truly these regional needs that are specific that need to be addressed, but it's not a one-size-fits-all model. So we can't just say we need to print all of the instructions in one language or the other, and that would solve all of the needs and solve all of the risk, because we can see here that the risk is different in different parts of the country. So all of the social determinants of health end up impacting many communities in different ways, and so we have to identify how to do that. We can look even at occupational risk, right? Looking at the risk for COVID-19 among individuals who have different types of occupation, that although many people, me and I'm sure many of us included, have been able to work virtually or work from home, we are well aware that there are many persons in our community who have been our essential workers, who work in healthcare or public safety, who are just unable to work from home for other reasons. And then we have those persons who do work from home. And what we see is that in the individuals who are more likely to have to still be in the workforce, we see a higher percentage of minority communities, a higher proportion of Black and Asian and Hispanic individuals in healthcare, in public safety, and those who are just generally unable to work from home. So even this further leads to and further amplifies the disparity, that it has nothing to do with the genetics of who a person is, and that a certain body is more likely to be infected. My Black body is not more likely to be infected with COVID-19, but perhaps if an individual has to work in other spaces, then that puts them at a higher risk. And again, looking at housing and access to affordable housing and multi-generational homes, a CDC study demonstrated that 67% of infected households reported symptoms, had household members that had symptoms within 7 days of an initial case. And so we know that there's household disparities for multi-generational homes, for overcrowded homes, when it comes to looking at marginalized communities and looking at Black and Brown communities around the US. And so all of this, lays the foundation for, this is the context of the disparity. This is the context of the disease. And so I want to first then talk about testing, because testing is still very much an ongoing issue, that there are still people who are testing positive, still people who are contracting the virus despite our current efforts towards vaccination. And so right now, there are generally about 3 types of tests that are available. There are rapid antigen tests. There are the PCR tests that certainly received a lot of news. I think all of these tests have, and the antibody tests. And so there's different types of samples, certainly for each of the tests, and they look for different things. The antigen test looks for different parts of the virus protein, while the PCR test actually looks for the genetic material, the RNA that makes up the building block of the virus. And then the antibody test looks for the antibodies that are produced in your body. And there's different times in which the test should be used, or that at least they've been approved for use, and when we're likely to be able to detect the virus when we're looking at all of these different types of tests. The challenge, though, that we've all seen, and it certainly was a huge challenge early in the pandemic, was access to testing, and access to testing sites was a major problem in the initial months of being able to control the pandemic. In early April, the median time to a testing site was 20 minutes. But when you start to zoom in and you narrow in on populations, and you start to look at access, though, for minority communities, then you start to see that once again a disparity emerges. So if we look at the macro level, one could imagine that 20 minutes driving to a testing site would be acceptable. However, if we begin to look at the access to transportation and those who may need to have access via public transportation, that access time begins to change. And then when we look at the access based on minority population, and we see this example here in Texas, that in this region where we have an increased non-white population over here in the southern part of Texas, now the distance to a testing site begins to increase compared to these populations that have a larger white population. And so again, at this macro level, we say 20 minutes to get to a testing site doesn't sound like a problem, but when we factor in the ability for an individual to arrive based on their transportation means, or we dial in and look county by county, zip code by zip code, and really tap into the disparity, that's where we began to see the challenges. And so I want to just give you an example of what my laboratory experienced as we were doing our testing for COVID-19. I'm sure you can figure out which of these lines on this graph is the one for COVID-19. It would be this orange one right over here that begins to emerge in March of 2020. These other now very, very small curves are for all of the other viruses that we normally see in a respiratory virus season: flu, RSV, various other viruses that we normally see. But in March of 2020, COVID-19 just overwhelmed all of the other viruses. And then we began to do things like social distancing, wear masks, wash our hands. And we saw all of the other viruses begin to wane. And we see lots of COVID-19 in our community. My laboratory serves a large portion of New Mexico. And so we see this testing. If you'll ignore these five, this is actually 2020. The way the graph came up didn't quite work, so this isn't 2019. But if we just start right here, this is the number of test requests that my laboratory received for COVID-19 from March of 2020 all the way to our peaks over here in November of 2020. So this might not mean too much to you, but laboratorians would just about pass out, and I probably came close to passing out many times during this past year, because really what we saw was a 13 times increase in the number of test requests from a normal flu season. So this is what our flu testing map looked like from November of 2019 to April of 2020. We did about 47,000 flu tests. So, a normal flu season, that it's a rough year, but, during flu season, we know we have to do a lot of tests. The density of the map and the density of the color shows how many tests per county in New Mexico. And so you can see my laboratory has a very wide spread across the state of New Mexico. We do a lot of testing, but we have testing really localized in a few communities. This is Bernalillo County, where Albuquerque, the largest population center center in the state is. And we've got a laboratory, a satellite laboratory over here in this county and a satellite laboratory over here. But we don't do a lot of testing in some parts of the state. And for a normal flu season, that didn't so much matter. They were getting their tests somewhere else. It wasn't something we were really thinking about. But when the pandemic began in March of 2020, and this is data from March to December of 2020, we did over 650,000 tests for coronavirus. And so that's, like I said, a 13 times testing increase. But here's what the important thing here is that what we did was we made an intentional effort to increase access to communities that needed testing, that weren't normally tested, and we made the effort to try to fill in more of the map of the state. And so what you can see off first glance is that there is not a county in New Mexico where my laboratory did not perform testing. And in some counties, I have here just highlighted the increase by county. So in Bernalillo County, we actually see a relative increase that's very similar to our overall testing increase. We went up by 13% overall, and when we drill down, we only increased by 14 times in Bernalillo County. So, that's fine. When we look down here in a county down here closer to the New Mexico, Texas, Mexico border, we increased our testing year over year from where we did flu testing to coronavirus testing by 195%, 195 times. That is not a typo. That's, we did 195 times more testing in this community because we chose to make intentional access to these communities in the border regions. Similarly, over here, we did 25 times more testing up here. And this area is more of our Native American population, and up in our Navajo Nation communities, we increased significantly the amount of testing that we performed because it was about intentional access to serving marginalized and underserved communities rather than just focusing on where the population centers are. We still see that there's space for improvement because there are some communities where we only slightly increase the amount of testing that was performed. But this, in my estimation, is what intentional access and intentional focus on providing testing to communities that need it looks like. Where there's already large population centers, our increase was proportional to the overall increase. As we had communities that we know were disproportionately affected by the pandemic, our team went in and did extra work and worked harder to close, at least provide additional testing to those communities, and not just by a small margin, but by 25 times, and down here by 195 times to increase access to testing. And so that's just one example of a way that we can work through some of these social determinants of health when it comes to access and identifying ways that we can work with communities. And so switching over to vaccines, I just wanted to provide a little bit of background, again, because all of this stuff is in the news, and lay audiences don't necessarily see this on a regular basis. But clinical trial phases, of course, they go through multiple phases, with phase 1 being the preclinical stage, phase 2, safety, phase 3 is the efficacy phase, phase 4 is the approval and the licensure, and then phase 5 is actually the long-term analysis, where there's continual monitoring for safety and efficacy of the vaccines. Just for context, vaccines are granted, as are the tests, they are granted emergency use authorization. And so this is where the FDA can allow medical products to be used in these emergency situations, as long as they've had one phase 3 clinical trial that's demonstrated the vaccine safety and efficacy in a clear and compelling manner. And of course, there's the regulatory groups and committees that work in the FDA to review the data and determine the efficacy for authorization for emergency use. And to share just a little bit about how do these vaccines work, because I know that is a big question that many people wonder about. We have currently 2 approved mRNA vaccines, the Pfizer vaccine and the Moderna vaccine. These are mRNA vaccines, whereas there's a portion of mRNA. So that's some genetic material that our bodies naturally produce and use to make proteins. And so the vaccine is injected, and your ribosomes inside your cells, they process the mRNA and they make proteins, and then that mRNA is degraded. In another case, and I only bring it up because there are two vaccines potentially pending, Johnson & Johnson and the AstraZeneca vaccine, that are not currently authorized for use in the US. They use a different type of delivery mechanism where they inject, again, some genetic material that is processed in your body. That material is degraded, and then your body produces the proteins that starts the immune response. So what does this immune response look like? Well, this over here, I certainly don't want you to figure anything out, but to understand that our body's immune response has been extremely well studied, and these vaccines are activating a cascade of responses, a cascade of B cells, which produce antibodies. They're activating T cells, and your T cells help your B cells to make antibody, and they help to kill infected cells. This is what our bodies do anytime they're exposed to a foreign infection or exposed to a pathogen. And these are mechanisms that have all been well studied, and there's this huge cascade of response that our bodies make towards whether it's a natural infection or a vaccine that we respond to. And of course, we've seen much information about the performance of the vaccine. Both of the approved vaccines do seem to perform quite well, and similarly, where they're very effective at preventing infection, and both of these are 2-dose vaccines. Within the vaccine trial for both the Moderna and the Pfizer, there was a strong effort towards increasing racial diversity during the trials. And so we can see that this is the US population here, so 12.3% population in the US for African American communities, and they approached that. They did not quite hit equivalence, but they certainly made an intentional effort to have diversity in the vaccine trials. And there's other vaccines that are in phase 3 clinical trials that I'm sure we'll be hearing more and more about as the weeks go on. Johnson & Johnson has a committee meeting at the end of February to discuss, for the FDA to discuss its efficacy. So what does it look like, and what has distribution of the COVID-19 vaccine in the US? How has it looked? Well, there was a CDC study that looked at the first around 13 million people who had received at least one dose of the vaccine. Important here is that race and ethnicity was only known for half of those individuals. 60% of them were white, and 39% represented racial and ethnic minorities. And so when it comes to the vaccine distribution, a lot of people say that maybe there's just a lot more vaccine hesitancy in minority communities. Maybe there's more people in minority communities and in the African American community that just don't want to get the vaccine. And so a study was done by the Kaiser Family Foundation. And what we see is it's actually not true that there's more minority persons, more Black persons, or more Hispanic persons who just outright refuse to get the vaccine. There's really no difference when we look at that compared to white people. What we do see, though, is that there's a larger proportion of people who are saying, I just want to wait and see. I'm not ready to quite jump on the bandwagon yet. And the way that I look at this is that I look at this as being, there are 43% of people that are convincible. There are 43% of people who have not outright said no. They just want to be convinced, and they just want to see evidence. And why is that the case? Because of everything that we talked about in the beginning, that there has been a system and a structure of healthcare and medicine that has created disparities that Black communities are probably quite right to distrust, and quite unsure about whether or not these healthcare, which has not always worked for us? Do we trust it to work for us now? And so I think this is a well-placed hesitancy. And then it becomes a responsibility of all of us to become more informed and to communicate what we know and what we understand about the vaccine, as well as to validate the experiences of people when it comes to vaccine hesitancy and why it's that way. Here's the thing, though, that's the most disturbing. We only have data for about 50% of people who have received the vaccine. And this is the data from the Kaiser Family Foundation. So you can't change what you don't measure is a common adage, but I often add that you don't want to change what you don't measure. And so for the states that are not yet reporting their vaccinations by race and ethnicity, I think it becomes an important thing for us to continue to push all of our states to report vaccinations by race and ethnicity so that we can identify those disparities. This is just a state by state comparison, and I certainly don't want to go through every I don't want to go through every state, but I do want to point some of these disparities out, because I will tell you, as I was preparing this portion of the talk, there was a level of righteous indignation that came over me when it came to looking at these disparities. So this is the total percent of people in the population, and I just want to point out some of these states and some of these communities. If we take a look at Colorado, so these are the share of COVID-19 vaccinations when it's reported by race and ethnicity. In Colorado, in Indiana, in Maryland, in Mississippi, and North Carolina, and Virginia, white people make up about 60% of the population on average. But have received 87% of the vaccinations. In a place like Indiana and in Pennsylvania, where the percent of population for white people is 80%, still 92% of the vaccinations. When it comes to our Black communities, places like Delaware, and Louisiana, Maryland, Mississippi, where Black population is 20 to 30%, we only get as high as 17% of vaccinations in Mississippi, and as low as 5 and 6% of vaccinations in states like Florida and Delaware, and Ohio. So we see that there is a disproportionate even distribution of vaccines in the states that are reporting vaccinations, which further amplify the disparity because case transmission is still happening. So now we have states in which there is decreased access to testing. We have communities and zip codes where there's decreased access to testing. And now those who are not being tested, who have a 4 times higher rate of hospitalization, a 2 times higher rate of death, are being vaccinated at less than a third, or even in some cases only 10% of their white counterparts. Now we see that once again, the system is not working in the favor of the persons who need access to vaccines. We see this even when it comes to our Hispanic populations as well. So in our Hispanic populations, where we look at the percent of white population to the percent of Hispanic vaccinated population, look at a place like Colorado, where Hispanics make up 22% of the population, but only 6% of the vaccinations, but 37% of the deaths, and 37% of the deaths and 22% of the cases of the deaths and the cases. Same thing in Florida, Hispanic people making up 27% of the population, but only 15% of the vaccinations, with 76% of vaccinations in Florida going to white people. So what we're seeing is this further divide when it comes not just to the initial pandemic and the social determinants of health, that we could not have changed. We could not have changed those. And I think it's probably impossible for us to imagine that we would have been able to change all of the social determinants of health between March and now December of 2020. But now when it comes to the vaccinations, this is now the active response and our active ability to go in and do something different. Still, once again, the system says, no, we're going to do what we have always done, right? And so we see these continued and these further marginalization of people and communities that's truly, truly unacceptable. Again, data for Hispanic people compared to white people. And so, the question about what determines health and thinking through these social determinants of health, where we learn, where we live, where we work, where we play. What we know is that we need to have access to both testing and vaccinations by people, for people, and around people who are where we live, where we work, where we learn, and where we play. That population, place, and power all have determinants on access to vaccination and testing. And so continuing to build collaborations such as this one, and raising awareness in populations and groups such as this one, where all of these conversations aren't just happening on the health side, but involving members of the social justice community, of the civil rights community, because health is a civil rights issue and health is a social justice issue. And today and right now, this means improving access to testing through intentional effort around bringing testing to communities, not requiring communities coming to you, to providing vaccinations to communities and not requiring that communities come to you for the vaccination. This is all about how we identify, how we can use these social determinants of health to be able to create a healthier path forward as we continue to fight this pandemic, but thinking through how we respond to the pandemics that our communities have already been experiencing and what the pandemics are ahead. And so there's a quote that's, we'll leave it as unattributed, but it says that every system is perfectly designed to get the results that it gets. So what we have to recognize, and I'm sure that we all recognize in whatever your area of social justice is and civil rights is that you already know that the system is not broken. The system is designed to get the results that it has been getting. And so this is not about fixing a broken system. This is about redefining a system and rebuilding a system in order to get different results. And so I go even further to say that people make up the systems, and that we can, each of us, use these individual systems and use our individual power to execute at a local level a change that can ultimately force systemic change. That it's not easy to change a system, but when we frame our minds instead around fixing a system and talk about creating new systems and using our individual power, then we can execute the local change. I just wanted to provide in my closing, these are just two wonderful books. I have a lot of my resources are throughout the presentation, but these are two wonderful books that I just wanted to be able to share with the community, looking at these opportunities for collaboration between social justice and health. And I thank you very much for your time, and I'm happy to take any questions.
Thank you for that incredibly wonderful presentation, Dr. Culbreath. You've given us so much information. I think I'm in information overload, and I'm ready to go out and do some more social justice work on making sure this vaccine is as distributed equally among all of our communities. So let's talk about some of the questions that we see in the chat and that have been presented. One of the first ones is, would you please give your opinion on which of the vaccines is probably most effective, and if there's one that's more effective for people of color than not?
So the data around the vaccines really has shown similar for the approved vaccines, has shown very similar efficacy for people of color, both the Pfizer and Moderna vaccine. I will just share my personal experience is that I received the Pfizer vaccine, but it's not, I certainly am not promoting the Pfizer vaccine. The data certainly looks like the efficacy is similar across the vaccines, and there don't seem to be any differences between the performance of the vaccine for Black people or any other minority community for either of the vaccines.
So thank you. The next question is, what if you have an adverse effect to the first dose of a vaccine? Should you then go and take the second dose?
So if you have an adverse event or adverse response to the first dose, you definitely need to just check in with your healthcare provider, especially if the response requires you to do that, right? So, you know, all of the same rules apply. If you feel like you need to have medical attention, you go and seek that out. And then you need to have a conversation about your decision around taking the second dose. What we have seen is that there do seem to be more side effects, not necessarily adverse events, but more side effects during the second dose of the vaccine. Anecdotally, again, this isn't data, it's just a personal experience. I did not personally experience any side effects, but I do have colleagues and friends and others who have personally, they just had some side effects to either the first or the second dose, with most of those side effects being injection site pain, up to and including low-grade fever, some muscle aches, kind of feeling that kind of achy part of a cold or a flu that one may have. For most people, it lasts 1 to 2 days, and then those symptoms completely resolve. What those side effects show us is that your immune response is working. This is how our bodies respond to pathogens. What many people don't realize is that most of the physical response that you have to an infection is not actually the infection. It's not actually the virus or the bacteria. It's your body fighting it off. And so what you're seeing when those side effects of the fever and the injection site pain, the body aches, that's your response to the vaccine, where your body is mounting an immune response. I have to admit, I was a little bit jealous of everybody's side effects because I started to question my own immune response. I was like, come on, B cells, come on, T cells, get moving. But regardless of whether or not you have side effects, as long as you have the 2 doses, it definitely, the data shows that there's very good efficacy, irrespective of how active your immune response is during the vaccine. But I was a little jealous of all the side effects that people were having.
Well, thank you, Dr. Culbreath. Another question that was raised, the questioner asked, you mentioned that there were times when you made directed attempts to go to areas around Texas and New Mexico that border to make sure that testing occurred. Do you find that it is more effective to make sure that people of color are getting the vaccine by taking the vaccine to them rather than waiting for them to come to the vaccine?
So I believe very strongly in the communities responding to the needs of the community. And we see that, there was so much to have even considered sharing for this, but we see that when it even came to testing for HIV, that when the testing is in the community, in Black communities, performed by Black providers, testing occurring at Black churches or part of Black community organizations, we see higher testing rates. So doing that same type of effort of bringing the testing closer to communities, we actually built a brand new laboratory from scratch in a Texas-Mexico bordering town here in New Mexico. So we went down there, we built the lab. The laboratory is staffed by people who live there. The specimens are collected by people who live there. And that's the county where we see 195 times the amount of testing done compared to when we were just doing flu testing and just getting whatever specimen and not really being intentional. I believe that same thing would show up for us when it comes to coronavirus. The challenge that we have right now is an issue of supply and demand, which, this is on the news every day. And so as the supply increases, I believe there must be a concerted effort towards having communities as vaccination sites rather than individuals having to go to these very large vaccination events or having to go outside of their community. We need to get the vaccine into the community and administered by people who are in the community to be able to reach the highest numbers and working with those trusted individuals and partners.
So Dr. Culbreath, what would you tell someone who's had an active autoimmune disease about taking the vaccine in light of the 45-year-old man who recently died after receiving the vaccine, who was immune compromised?
So that definitely has to be a conversation with your provider. There's so many different autoimmune diseases, different medications that people may be taking for their autoimmune disease. So there's not one blanket answer to give other than to have an active conversation with your provider, not just any doctor friend that you have, but really talk to your provider, work with your healthcare team. But again, right, going back to those layers of disparity, do we have all the access to our providers that we need? Hopefully, during the pandemic and the increased availability of telehealth, that access and some of those barriers have gone down. But I really recommend working with your provider and finding out what the right course of action is.
So thank you. And the very last question that we have today is, what about the vaccine and pregnant women? Has that been affecting, that vaccine been affecting the unborn child in any way, as far as you can tell?
Right. So I think, again, conversations with the provider are necessary, but most of the OB and gynecology groups have come out saying that they do support pregnant women to be able to get the vaccine. So they're not, the OB-GYN organizations are not opposing vaccination in pregnant populations. But again, having a conversation with your doctor or your midwife to be able to decide what the best course of action and the best timing of that during your pregnancy would be the best recommendation.
Thank you. Well, Dr. Culbreath, we sincerely appreciate the time that you've given us today. We do want the audience to know that Dr. Culbreath has agreed to make her slides available to everyone who registered for this event. You can see her presentation again on YouTube, so you can watch it over and over and get well-versed so that you can go and give your own presentation pretty soon. We want to thank you all for attending this free webinar. And we also want to thank again the generous supporters for this program, being the law firms of Sanchez, Mauer, Desiderio, and the law firm of Friedman, Boyd, Hollander, Goldberg, Urias, and Ward. Now, the section of Civil Rights and Social Justice provides free webinars and resources for legal professionals and advocates nationwide. And we hope that everything that we provide helps you in your work. If you are not already a member of the American Bar Association, then become a member. And when you do become a member, join the Civil Rights and Social Justice section, and then become an active member of the African American Affairs Committee. You may begin this incredible journey by going to ambar, that's ambar.org/CRSJ. You can find information on other free programs on the CRSJ website. Now, before we go for one last moment, Dr. Culbreath, because we have just a couple of minutes, we have one more question for you. And that question is, will you come back again in about 6 months and give us an update on what's happening with this vaccine? And are we still seeing a disparity among people of color and not?
I'd be happy to come back if you'd have me.
We will definitely have you. So best of luck to you. Best of luck to everybody. And join us again for the next webinar presented by the Civil Rights and Social Justice section. Have a great afternoon. The list of books that Dr. Culbreath has will be on her slide presentation. You will see that list when you receive it as a part of the mail out that will be sent to everybody who registered. Have a great afternoon and stay well and washy-washy.